One of the things that women surprisingly get up in arms about when I talk about regarding hormonal health is the fact that there is no testing required to determine your dose of hormone replacement therapy. And I wanted to talk about this because I've recently got a lot of heat on social media by posting that one of the hills that I will die on as an evidence-based practitioner is that you don't need a Dutch test or any hormone test at all to determine whether or not your hormone replacement therapy is doing what it needs to do. And I want to elaborate on that because I think this is a really interesting conversation to have. And the reality is, when you're talking on social media, we're talking about things that are extremely nuanced, personal, and individualized. But as a standard of care, as a standard of practice, we know that testing hormones when somebody is on hormone replacement therapy is largely unhelpful. And it does a disservice to some patients, as I've seen some patients have their levels tested, and based on whatever that arbitrary level is, their practitioner says, oh, your dose is too high, we need to reduce it, when the patient may have been getting relief from the dose that they were on. And so here's the rationale behind that conversation, because I've been personally called negligent as a provider. People have told me that providers in the past, the reason why they haven't gotten results or they've felt awful in the past is because they didn't have testing done on their hormones. And once they had testing done, they were able to find the right dose and they were able to get their symptoms treated. Now, I would be curious what that level would be with that dose, because there's no documented evidence that tells us this information. But here's the reason why. And as a naturopathic doctor, I find that I'm often towing the line between the conventional system, which we know is largely flawed, and the way a lot of patients feel about the conventional system. And the reality is when patients come to see me, they've often been, for lack of a better term, I'm their last resort. They've often been jaded by the conventional medical system. The conventional medical system has dismissed them. They feel like they haven't been listened to. And especially in the women's health space, we often are told that, we should just deal with it, or it's just part of being a woman. I've had practitioners tell patients that they couldn't have hormone therapy when it was very clearly indicated. And so while I want to explain to you why testing is not necessary while you are on hormone replacement therapy, I don't want you to confuse that with the idea that I also, if you feel that your provider doesn't care or doesn't listen, this is not a way to dismiss somebody. In fact, in my strong opinion, this is actually a way to get you the best clinical care. And it's interesting because when I have this conversation with patients, I either get a resounding, feeling dismissed. But when I talk about testing, there is the sentiment where, naturopathic doctors want to do too many testing and there's all this functional testing and it's so expensive. And so when I come at it from a hormone perspective and I say to patients, you don't need good news, you actually don't need this, because not only is it a waste of your money, but it's not going to change your clinical decision. People get they get their back up a little bit, because I think it reminds them of a conversation or an interaction with a provider who didn't listen to them and wouldn't investigate when something is wrong. And that's not what this is. So let's just talk about what this is. When we look at menopause hormone therapy, okay, we are giving this largely to people in perimenopause and menopause. Statistically speaking, someone is in perimenopause if they have symptoms of it and they're over the age of 45. Now, what we do is we use something called the straw criteria. This stages of reproductive aging criteria basically lets us know where someone is probably at in their cycle based on bleeding. Okay? So the caveat here is that if you don't fall into this criteria, we're talking about standard general population, most common clinical practice, right? But if you don't fall into that category, that doesn't mean we dismiss you and throw you over here. It means we take a different approach. So what I'm not saying, people like to hear what I'm not saying, but what I'm not saying is that we never test hormones ever in women and it's not helpful ever. I'm not saying that. What I'm saying is that if someone is of the statistical age of perimenopause, if they are 47 and their periods are starting to be irregular, they've missed 7 days or more, maybe they're in the second stage where they've missed over 60 days of a cycle, and then it comes back, and then they randomly miss a cycle, and then they miss 2. Like, if they're looking like they're in perimenopause and there's not a health history that tells me that there's another reason for the irregular periods. For example, PCOS, now renamed PMOS, is a metabolic condition where you might have lifelong irregular periods. And so you're probably not a great candidate to determine whether or not irregular periods tell us if you're in perimenopause. See what I'm saying? So in someone who doesn't have a previous condition, who's going through their cycles are regular, now they're 47 and now they have hot flashes, night sweats, trouble sleeping, you name it, and their periods are irregular, we know that hormone therapy can be beneficial for them, specifically to treat their hot flashes and night sweats. When we look at the indications for hormone therapy, it's vasomotor symptoms. And oftentimes when we treat their hot flashes and night sweats, we often help their sleep, because a lot of times that core temperature dysregulation was one of the reasons why they weren't sleeping. And so even if someone doesn't wake up sweating or have to change their clothes or is in any sort of severity where they're like, oh my goodness, my hot flashes and night sweats, still treating them with HRT for those vasomotor symptoms, that temperature dysregulation problem can be really, really advantageous. So that patient gets put on a standardized dose. Now, in my practice, I start at the lowest dose because my opinion is that lowest effective dose is the goal here. And so we talk about the pros and cons. We put somebody on estrogen and progesterone. Progesterone is largely a standardized dose. We typically give it here in Ontario. I'm only coming from where I practice. Here in Ontario, the standard of care is oral micronized progesterone at 100 milligrams per tab, or we can give the progestin IUD. That's the most common. There are some patches that are combo products, but just to make this conversation really easy and streamlined. The first thing is we give the progesterone. Now, I say to patients, the good news is we don't really have to change your progesterone much unless you largely don't tolerate it. Again, it can help with sleep, it can act on the GABA receptors, and it helps protect the lining of the uterus from too much unopposed estrogen. That's one of the reasons why they started giving progesterone. But we later found out that it can have other benefits, specifically the oral micronized progesterone. But it comes in 100 milligrams. And so if there's a reason why you shouldn't be on that, or you are allergic to some of the components, specifically if you have a peanut allergy, we reassess. But 100 milligrams is where we start. What changes in your HRT protocol the most is the level of estrogen. The level of progesterone will change if we feel that you're not achieving proper sleep, or if your estrogen is not unopposed enough. If your estrogen is not opposed enough. So if your estrogen is at a level where we think we need to increase it, i.e. you're having weird bleeding all of a sudden, we may, after a thorough investigation of an ultrasound and looking at the lining, choose to increase your level of progesterone. That's where we look at that nuance. If progesterone is having someone bloated and constipated, we look at adjusting the dose in that way. Now, typically we use a standardized questionnaire to go through symptoms and see how a patient is doing. And that is how we determine the dose. What's wild about it is this is a really cost-effective way to evaluate things. And not only is it cost-effective, but it is evidence-based. We know that there's not a single serum value that tells us that you have resolution of symptoms. You can tell us that. And that's where listening to the patient and having a really thorough conversation is really important. Understanding, I get a rating, I get a standardized rating, I go through the scale with the patient, and I get an idea of whether or not they're doing well on their current dose. And if I don't think some symptoms are resolved that should be, i.e. hot flashes, then I increase the dose. We reassess in 3 months and we see where we're at. Being mindful that from a naturopathic perspective, my goal is to use HRT and have my patients on HRT as a tool in my toolbox. As a naturopathic doctor, what I am most interested in is actually understanding the whole picture, because we know that if you look at the list of symptoms of perimenopause, it often overlaps with the list of symptoms of insulin resistance, inflammation, nutrient deficiencies, etc. And so when we're looking at the whole picture, HRT is part of the conversation and everything else is also. And so we test a lot of those other pieces. We look at thyroid, we look at insulin, we look at inflammation, we look at your iron, because oftentimes that can cause a lot of problems that look like perimenopause, sleep issues, hot flashes, night sweats, mood swings, lots of anxiety that crops up, right? A lot of times what's going on is multifactorial. HRT is weight neutral. There is some bloating and constipation that can happen at the beginning of starting progesterone, but HRT is largely weight neutral. And so it's not going to make you gain or lose weight, but weight gain happens in perimenopause and menopause. And so we need to look at this from a perspective that inflammation goes up as we go through perimenopause and menopause. Insulin resistance goes up And we need to look at all of those pieces in context. And so, if your practitioner is telling you that you need to test your hormones while you're on HRT, I would wonder why, right? What is that giving you that you cannot get otherwise? How is that changing your dose? What number are they looking for? Because there's really no standardized solution to that. And doing expensive testing isn't going to get you further than you're going to get with a routine follow-up with your practitioner discussing how things are going while looking at the bigger picture. Now, this is not to discount or change the role of hormone testing in other scenarios. If someone is under the age, the statistical age of perimenopause, and they are having irregular periods, symptoms that are going on with that looks like perimenopause when really they shouldn't be, we need to understand that. So testing hormones can be effective in those scenarios, and I am often doing it. I'm also testing hormones in a scenario where somebody has had a hysterectomy. They have no bleeding patterns. Someone has had pelvic radiation. Their ovaries potentially are not working at all, right? We have different scenarios where that is a really real and evidence-based look at the hormones. But again, from a hormone replacement therapy monitoring perspective, it is not evidence-based to test your levels. So if someone tells you it is, that is just not true. If you have questions, I'm happy to chat further. Comment below.